In the following slideshow, I will give you an overview of neurosurgical management of tumors of the pineal region. I will cover basic pineal gland anatomy, types of tumor pathology that can arise in the pineal gland, clinical features of pineal tumors, appropriate workup and diagnosis, as well as the nuances of surgical management and follow-up of these tumors. First, some anatomical considerations. The pineal gland is an extraaxial structure near the geometric center of the brain. This fact is important for surgery alone, as any approach will require a long reach from your craniotomy to the pineal gland itself. Moreover, the pineal gland is surrounded by various critical structures, especially crucial venous structures. The anatomical boundaries of the gland are listed above. The main consideration, however, is the relationship of the gland to veins, as mentioned. The velum interpositum is just dorsal to the gland and contains the internal cerebral veins. These veins then join with the basal veins of Rosenthal to form the vein of Galen, which sits just dorsal and posterior to the gland. Of course, avoidance of injury to any of these veins is critical during surgery, as sacrifice or partial occlusion could lead to significant deep and diffuse venous infarcts. In terms of pathology, while the pineal gland itself is a small structure, there is a large variety of tumor pathology that can exist. This fact is secondary to the various cell types within the pineal gland itself. Pinealocytes, astrocytes, endothelial cells, and sympathetic nerve endings all exist. In general, 5 categories of tumors can arise, each with varied prognoses and treatment paradigms. They are germ cell tumors, pineal parenchymal cell tumors, glial cell tumors, papillary tumors, and other, or miscellaneous tumors and cysts, including meningiomas, hemangioblastomas, choroid plexus papillomas, METs, lymphomas, and vascular lesions. In terms of clinical presentation, patients with pineal lesions tend to become symptomatic in 3 ways. Given the proximity of the pineal gland to the posterior third ventricle and aqueduct of Sylvius, patients can develop obstructive hydrocephalus and increased ICP, in which case they present with headache, nausea, vomiting, cognitive impairment, papilledema, ataxia, and even obtundation. The tumor can also directly compress the brainstem and cerebellum. The classic syndrome of such compression is Parinaud syndrome, or dorsal midbrain syndrome. In this case, the tumor compresses the rostral interstitial nucleus of the medial longitudinal fasciculus, leading to paralysis of upgaze, convergent retraction nystagmus, and light near-pupillary dissociation. More rarely, these tumors can present with endocrine dysfunction resulting from tumor infiltration into the hypothalamus. The expedient workup and diagnosis of pineal tumors is crucial to ensure the appropriate treatment of these varied pathologies. Of course, imaging with contrast-enhanced MRI is of utmost importance in order to better visualize the lesion, as well as its relationship to and effect on other structures, including veins and the ventricular system. Collection of tumor markers from the blood and CSF is also important. Alpha-fetoprotein and beta-HCG should be checked in the blood and CSF prior to biopsy or resection, as high elevations in these 2 markers are pathognomonic for malignant germ cell tumors, which are treated with chemotherapy and radiation and not surgery. Additionally, these markers are useful for monitoring response to such therapies for malignant germ cell tumors. Given that patients often present with symptomatic obstructive hydrocephalus, this issue may need to be addressed prior to a full diagnostic workup. CSF diversion can be achieved via EVD, ETV, or shunting. If ETV is performed, often an EVD is left in place if open surgery is likely to follow. In any of these cases, CSF sampling for tumor markers should be performed. Once hydrocephalus is temporized, assuming no pathognomonic CSF markers are found, tissue diagnosis is required. Tissue diagnosis can be achieved via stereotactic or endoscopic needle biopsies or through open surgical procedures. Clinicians may advocate for one or another of these approaches as a standard, but there are benefits and pitfalls to each of them. Open surgery. Once open surgery is considered or decided upon, there are many nuances that must be taken into account. First and foremost, surgical approach must be decided. The approaches to the pineal region are divided into supratentorial and infratentorial. In the infratentorial group, there are the midline and lateral, supracerebellar, infratentorial approaches, SCITs. In the supratentorial group, there are the transcallosal interhemispheric, occipital transtentorial, and transcortical transventricular approaches. Each of these approaches requires careful patient positioning and head positioning in order to maximize tumor visualization and minimize obstruction of the surgical corridor by surrounding structures. For the SCIT approaches, sitting position is ideal. A reverse electric operating table is preferred. It allows gravity to retract the cerebellum off the tentorium and reduces pooling of blood in the operative field. It is favorable for tumors that extend superiorly into the third ventricle. For the sitting position, the patient is placed supine on the operating table. The headrest is removed and the patient's shoulders are brought to the edge of the bed. The back of the table is then elevated to its maximal position while an assistant supports the head. The head is flexed so that the tentorium is approximately parallel to the floor, allowing optimal exposure of the tentorial notch. Care must be taken to avoid endotracheal tube kinking, jugular vein compression, and cervical spine injury. A pin vise head fixation device is then secured and mounted to a bed attachment near the foot of the bed, so that the patient is maintained in this forward flexed position. The patient's legs should be elevated to assist venous return and decrease sciatic stretch. Of course, in this position, there is risk of venous air embolism, and precordial Doppler and tidal CO2 monitoring, and close communication with anesthesia is requisite. The occipital transtentorial and transcallosal transventricular approaches are facilitated by the lateral decubitus and 3/4 prone positions. For the lateral decubitus position, the dependent non-dominant right hemisphere is positioned down. For the OTT, the head is rotated downward, with the nose 30 degrees towards the floor. For the transcallosal approach, the head is raised approximately 30 degrees above the horizontal in the mid-sagittal plane. The 3/4 prone position, pictured here, can be cumbersome and requires placing an axillary roll under the patient's right axilla with the right arm supported in a sling-like fashion beneath the patient. A supporting roll is placed under the left thorax, and a 3-point head pin vise holder is used to support the head in a slightly extended and rotated position to the left at a 45-degree oblique angle. The patient is securely strapped, and the legs and feet are elevated and flexed to facilitate venous return. This positioning is suitable for more posterior approaches, such as the occipital transtentorial as opposed to the transcallosal approach. The non-dominant hemisphere is easily retracted with the help of gravity. The prone and concord positions can also be used for the midline and lateral SCIT approaches. The positioning is straightforward as pictured here. While these positions benefit from the lack of risk of venous air embolism, the benefits of the sitting position in terms of the natural cerebellar retraction by gravity and lack of blood pooling are lost. The SCIT approach is ideal for tumors inferior to the deep cerebral veins and without much lateral or caudal extension. The steep trajectory over the vermis provides an upward-looking angle, which is beneficial for tumors that extend rostrally into the third ventricle. The patient is placed in the sitting position. If necessary, a ventricular drain can be placed. The surgery is begun through a linear midline incision extending from just above the torcula and external occipital protuberance down to the level of C4 spinous process. The incision is brought through the nuchal ligament of the suboccipital musculature. It is not necessary to detach the muscles from the spinous processes of C1 and C2, and the foramen magnum does not need to be exposed. The craniotomy is centered just below the torcula and should expose a small portion of the sagittal sinus, the torcula, and the transverse sinuses. Bone should be removed above the transverse sinus to ensure that the view along the tentorium is not obscured. A wider craniotomy is preferred as it provides space for instruments and light. The dura is open in a gentle upward-facing semilunar curve below the transverse sinus, extending from the lateral aspects of the exposure. The dural flap is reflected upward and placed on slight tension to retract the sinuses without occluding them. The inferior dura acts as a sling to support the cerebellar hemispheres. If the posterior fossa is tight, fluid can be removed from a ventricular drain or by opening the cisterna magna. The exposure proceeds by cauterizing and carefully dividing the arachnoidal adhesions and midline bridging veins between the dorsal surface of the cerebellum and the tentorium. Only midline bridging veins over the dorsal surface of the cerebellum that interfere with the approach or retraction should be sacrificed. All lateral bridging veins should be preserved. When these attachments are divided, the cerebellum drops away from the tentorium to provide an excellent corridor with minimal brain retraction. The dorsal surface of the cerebellum can be protected with padding such as sulfa, and a small brain retractor can be used to generally provide additional cerebellar retraction in a posterior and inferior direction. The dissection is then continued anteriorly along the undersurface of the tentorium. Additional adhesions and bridging veins can be divided when they become visible near the anterior vermis as the cerebellum is retracted. With the retractor in place, the opalescent arachnoid covering of the pineal region can be seen. This arachnoid is usually thickened and must be opened with sharp microdissection. The precentral cerebellar vein is identified as it courses from the anterior vermis to the vein of Galen and should be carefully dissected, cauterized, and divided as far as possible from the confluence of the basal veins to avoid thrombus progression. It is not advisable to cauterize or sacrifice any other veins of the deep venous system. With the posterior surface of the tumor exposed, the central portion is cauterized and opened with a long-handled knife or bayonet scissors. The tumor is then internally debulked with a variety of instruments such as suction cautery tumor forceps and an ultrasonic aspirator if necessary. The dissection continues until the third ventricle is encountered. The tumor is then carefully dissected inferiorly off the brainstem. This is often the most difficult portion of the dissection, as the tumor is often adherent. This dissection can be facilitated by retracting the tumor superiorly and bluntly dissecting the brainstem interface under direct vision. Finally, the tumor is removed superiorly after separating the attachments along the velum interpositum and the deep venous system. The lateral SCIT is a modification of the midline approach. The steps are similar, but it allows for preservation of midline and lateral cerebellar bridging veins. Again, the sitting or lateral decubitus position is used. The head is again flexed, but this time rotated slightly ipsilateral to the side of the incision, thereby bringing the incision towards the center of the operative field. A 7 to 8 centimeter linear incision is made halfway between the inion and the mastoid, extending 1/3 above and 2/3 below the transverse sinus, as pictured here. A small paramedian craniotomy, which exposes only the ipsilateral transverse sinus, is performed while leaving the torcula protected. A single upward-facing semilunar dural flap is opened and retracted towards the sinus, where the tentorial retraction sutures are used to elevate the transverse sinus and expand the operative corridor. CSF release through a lumbar drain facilitates retraction of the cerebellar hemisphere caudally. The surgical corridor is developed above the cerebellum and beneath the tentorium. Large median and lateral bridging veins should remain intact if at all possible. Arachnoid dissection and tumor resection is carried out as with a standard SCIT, with care to preserve the arachnoid membranes of lateral structures such as the SCA or the trochlear nerve. For the OTT, a 3/4 prone position is generally preferred. This approach to the pineal region uses an oblique trajectory for lesions that are essentially midline and may therefore be disorienting to surgeons who are not familiar with it. By dividing the tentorium, excellent exposure of the quadrigeminal plate is achieved, thus making it particularly useful for tumors that extend inferiorly. A U-shaped right occipital scalp flap is reflected inferiorly with a median vertical limb beginning just to the left of midline at about the level of the torcula. A linear incision is also acceptable as pictured here. A burr hole is placed in the midline over the sagittal sinus just above the torcula, along with another burr hole 6 to 10 centimeters above this. A craniotome is then used to turn a generous bilateral craniotomy extending 1 to 2 centimeters to the left of midline. The dura is opened in a U shape and reflected towards the sagittal sinus. With the three-quarter prone position, gravity helps with retraction of the non-dominant occipital lobe. Under the operating microscope, the straight sinus is identified. The tentorium is divided just adjacent and parallel to the straight sinus. A retractor can be placed over the falx for exposure. The inferior sagittal sinus and falx can be divided to facilitate further falcine retraction. Once the tentorium is divided, the arachnoid overlying the tumor and quadrigeminal cisterns can be seen. Tumor removal proceeds as described earlier while taking care to avoid injury to the deep venous system. The transcallosal interhemispheric approach provides a corridor to the pineal region along the parieto-occipital junction. It provides wide exposure and may be desirable for a tumor extending anteriorly into the third ventricle with wide lateral extension. The prone or sitting position is generally preferred. A wide craniotomy, roughly 8 centimeters in length, provides flexibility in determining the corridor and avoiding bridging veins on the cortical surface. The craniotomy is generally centered over the vertex and thereby the parietal lobe to avoid manipulation of the occipital lobe. A burr hole is made over the sagittal sinus both anteriorly and posteriorly, and a craniotome is used to turn a generous craniotomy. The craniotomy should extend 1 to 2 centimeters to the left of the sagittal sinus on the contralateral side, thereby providing room to place retractors in the intrahemispheric fissure. The dura is opened in a U-shaped fashion and reflected medially towards the sagittal sinus. The bridging veins are inspected, and an approach is chosen that will minimize the number of cortical veins sacrificed. Beyond the cortical surface, this is generally a non-vascular corridor with few adhesions between the falx and cingulate gyrus. As such, the corridor should open without requiring any vessel sacrifice. Once the fissure is open, the white corpus callosum is easily identified. The paired pericallosal arteries running over the corpus callosum should be identified. These arteries are retracted either to one side or with separate retractors to each side. Using a combination of suction and cautery, the corpus callosum is opened directly over the largest portion of the tumor mass. A 2 centimeter callosal opening is usually performed and is not likely to lead to disconnection syndrome or cognitive impairment. Once through the corpus callosum, the dorsal surface of the tumor should be visible, and the veins of the deep venous system must be identified early to prevent damage to them. Once the tumor is exposed, it is debulked and then dissected as described previously. There are various potential complications of pineal surgery, which range in severity. Some of these can occur regardless of approach or positioning, while others are more particular to the chosen operative approach. On the minor end of the spectrum, regardless of approach chosen, patients frequently have some impairment in extraocular movements in the immediate postoperative period, particularly limited upgaze and convergence. Some degree of pupillary impairment with difficulty focusing may also occur. Many of these extraocular problems are transient and resolve within the first few days, although they can persist for several months. Permanent major impairment is rare, but some mild limitation of upgaze is not unusual and has little clinical significance. Similarly, ataxia is frequently present but resolves within the first few days after surgery. More severe morbidity is rare, but can be the sequela of aggressive brainstem manipulation. This can lead to cognitive impairment or, in its extreme form, even akinetic mutism. Such complications are more common in previously irradiated patients, patients with invasive tumors, and those who were progressively symptomatic preoperatively. The most serious complication of pineal surgery are generally related to postoperative hemorrhage, which can occur for various reasons and are often independent of surgical approach used. Another potential vascular complication is venous infarct, which can extend into the midbrain with devastating consequences. This rare and unpredictable complication is thought to be the result of venous insufficiency in a small subset of patients who cannot tolerate the sacrifice of bridging veins in the cerebellum. Some complications depend on the approach used. Complications related to the sitting position include subdural hematoma, hygroma, and ventricular collapse. These conditions are generally self-limited. Air embolism is rarely a problem, but can be anticipated by a drop in end-tidal carbon dioxide levels or with Doppler monitoring. Complications of supratentorial approaches include hemiparesis from brain retraction or from sacrifice of bridging veins. Fortunately, these deficits usually resolve spontaneously, and infarction and permanent deficits are rare. Seizure prophylaxis is desirable in the immediate postoperative period, although long-term use is not necessary. Parietal lobe retraction can cause sensory or stereognostic deficits on the opposite side. Occipital lobe retraction during the transtentorial approach can cause visual field deficits. Although disconnection syndromes have been reported with corpus callosum incisions, this has been rare in our experience, even when the splenium is divided. Surgery in the pineal region is amongst the most difficult microsurgical challenges, and outcomes vary substantially with the expertise of the individual surgeon. With modern microsurgical techniques, surgical series that include more than 20 patients report operative mortality of 0 to 8% and permanent morbidity of 0 to 12%. The impact of surgery on long-term outcomes depend on the tumor's histology and responsiveness to adjuvant therapy. With benign tumors such as teratomas, cystic pilocytic astrocytomas, dermoid tumors, epidermoid tumors, and low-grade pineocytomas, expectations include complete surgical removal, excellent long-term follow-up, and probable cure. With malignant tumors, the paucity of surgical series reported in the literature makes it difficult to draw conclusions regarding the effect of the degree of resection on outcome. The anecdotal evidence, however, is that except for germinomas, which are highly radiosensitive, greater resection improves the prognosis and response to adjuvant therapy. Outcomes and type of continued care, of course, depend greatly on the pathology of each individual tumor. Surgery is often curative for benign tumors, including meningiomas, dermoids, epidermoids, teratomas, pineal cysts, pilocytic astrocytomas, and well-differentiated ependymomas and pineocytomas. In most cases, such benign lesions are usually well-defined and as such easily resected in their entireties. In rare instances where a benign tumor is incompletely resected, the patient can often be managed conservatively with observation initially. Within the glial category, tumor grade ranges from benign and low-grade gliomas to glioblastoma. Glial tumors in the pineal region can originate from astrocytes in the pineal gland itself. These lesions tend to be encapsulated and cystic, resembling the appearance of pilocytic astrocytomas. They are amenable to gross total resection and have excellent outcomes. Gliomas that arise from the brainstem and involve the pineal region are often tectogliomas that extend rostrally. Following an endoscopic third ventriculoscopy to initially treat the hydrocephalus, subsequent management is often conservative with observation alone. Some authors recommend biopsy or resection and radiation for growing lesions. Ependymomas can originate in any location along the ventricular system and grow posteriorly into the pineal region. As in other locations, the prognosis for ependymomas of the pineal region is highly dependent on tumor grade. Nevertheless, ependymomas in the pineal region tend to have a higher rate of recurrence than those in the lateral ventricles. While rare, glioblastomas can originate from the gland itself or more often from the thalamus. As in any case of GBM, safe gross total resection followed by adjuvant radiation and chemotherapy is advocated, though prognosis is poor. While there is debate as to the benefit of gross total resection and adjuvant treatment in pineal GBM, these principles from supratentorial GBM data are often applied in the pineal. Papillary tumor of the pineal region was reported for the first time in 2003 and introduced as a separate tumor entity in the 2007 WHO classification of CNS tumors. In a retrospective study of 31 patients with this tumor, 21 of the 31 patients underwent gross total resection and 15 received adjuvant radiotherapy. Despite this treatment, the majority had recurrences. The 5-year overall survival was 73%, with progression-free survival of 27%. A more recent retrospective meta-analysis of 1,164 studies yielding 177 cases of this type suggested that while surgery and small tumor size did improve 36-month survival, gross total resection or adjuvant therapy did not afford significant benefit. Pineal parenchymal tumors are thought to originate from the melatonin-producing cells of the pineal gland and include benign and aggressive subtypes. On the histopathological spectrum, pineocytomas are the most benign and pineoblastomas are the most malignant. Tumors of intermediate grade are referred to as mixed pineal parenchymal tumors or pineal parenchymal tumors of intermediate differentiation, PPTIDs. For pineocytomas, complete surgical resection should be the goal. A small subset of pineocytomas, representing approximately 16% of all pineal cell tumors, are discrete, encapsulated, histologically benign, and fully resectable. Surgery alone may lead to long-term recurrence-free periods without any additional therapy. Such patients, however, should be monitored closely with serial MRI. With subtotal resection, radiation does not seem to offer a significant benefit over observation. Pineoblastomas often appear identical to pineocytoma on MRI. They are indistinguishable from medulloblastomas by histological analysis and have similar clinical behavior. Like medulloblastomas, they tend to be more aggressive in children than in adults. Whereas there is no consensus favoring surgery for pineoblastoma, increased survival in both adults and children is associated with open surgery compared to biopsy. There are few published cases of stereotactic radiosurgery for pineoblastoma, and the results are poor. Prognosis and treatment of paradigms for PPTIDs are less clearly defined, as these have a heterogeneous clinical behavior. Various PPTID classification schemes tied to prognosis have been proposed. Given the histological spectrum and heterogeneity of tumor grade within a given lesion, accurate pathological diagnosis is unreliable in the setting of stereotactic needle biopsy. As such, open surgery may be favored. PPTIDs are often radiated in the presence of residual disease following resection, but it is unclear whether this is required following gross total resection of encapsulated tumors. In general, achieving GTR appears to be the most important predictor of long-term outcome. Germ cell tumors can be classified as either germinomas or non-germinomatous germ cell tumors, which include endodermal sinus tumors, choriocarcinomas, embryonal carcinomas, mature teratomas, and immature teratomas. Germinomas are the most common pineal region tumor, especially in adolescent boys and young men. Because they do not secrete a specific tumor marker and they cannot be distinguished radiographically from other types of tumors, diagnosis should be made with tissue confirmation regardless of age of presentation. Germinomas are exquisitely radiosensitive, and patients have excellent outcomes with radiation alone. Long-term control of germinomas is achieved in 90% of patients. Non-germinomatous malignant germ cell tumors, such as endodermal sinus tumors, choriocarcinomas, and embryonal carcinomas, have poor prognosis. These are the only pineal region tumors that should be treated without a tissue diagnosis because elevated levels of germ cell markers in the serum and/or CSF are pathognomonic for specific histopathologies. Following radiation chemotherapy, surgery may be necessary to treat the residual unresponsive disease in a strategy known as second-look surgery. In summary, there is a wide variety of histological subtypes of pineal region tumors, which makes tissue diagnosis essential in order to plan treatment. With current microsurgical techniques, we can achieve safe and aggressive resection of these pineal region tumors. In terms of operative approaches, the most commonly used are the supracerebellar infratentorial, occipital transtentorial, and interhemispheric transcallosal approaches. The choice of each of these approaches depends on the clinical and radiographic features of each tumor and each surgeon's individual experience. Excellent long-term prognosis follows resection of benign tumors, and even most malignant ones. Surgical resection alone is usually curative for benign tumors, while malignant tumors require adjuvant radiation and/or chemotherapy.